Welcome to Red Deer Public Library and Primary Care Network House Cafe. Today's topic is house screening, your house in 2022. And please welcome Dr. Nett, Nadine Pearson, and Jeannie Adair, who will be talking about why you need to do your house screening and what is involved in this process.
Thanks, Tatiana, for the introduction, and thank you to the Red Deer Public Library for facilitating this health cafe. So support nurses are here to do exactly what the name says, support the physician, clinic, and patient to provide quality and efficient health care. We're a team of knowledgeable LPNs who work in partnership with your family physicians and other healthcare professionals. In 2015, the Red Deer physicians requested nurses to be in this role, and we reach out to patients who don't typically come in to see their doctor. We connect with patients in clinic to optimize their time with their physician and support the clinics and doctors with new health initiatives. Our team can also assist you in navigating PCN and community resources, as well as connect patients to their family physician's clinic, which is your medical home, for better health outcomes.
Thanks, Ginny, for introducing your role as a support nurse in the clinic. I'm Dr. Swayrath Neth. I'm a community family physician. Before we discuss health screening, I wanted to discuss the principles of screening as a tool to promote population health. So as a general rule of thumb, screening tests are used for the early detection of disease in asymptomatic individuals. So it's very important to know that individuals who have symptoms no longer qualify for screening tests. And in fact, we should be using diagnostic tests to work up their presentation or their disease state. In addition, the disease should be common, it should be life-threatening, and also treatable. There's no value in screening for a disease if we really don't have any options for treatment. The disease should be detectable in the early stages of the illness while the individual is asymptomatic. This way, we're able to offer treatments early in the disease process. And also the natural history of the disease must be known as well. That is to say, how the disease behaves in the next 10 or 25 years, so that we're able to offer a plan of treatment. The screening test, so that's important as well. So the screening test should yield very low probability of false negatives and low probability of false positives. So in regards to false negatives, if there's a high chance of finding false negatives, then we're actually not finding the disease that we're looking for in the first place. If there's a high chance for false positives, then we're actually chasing something else, and this could actually lead to more investigations that are unnecessary and even treatments that are not necessary as well. The screening test should also be quick to do, easy to do, safe and inexpensive. That way we can apply it to the general population. So I hope that gives a good quick introduction to health screening, and I will hand it over to Nadine.
So what is Alberta screening and prevention, and why is it important? So the focus of Alberta Screening and Prevention, or ASAP, is to support family physicians and clinic teams by offering preventative screening tests to their patients at routine appointments and calling patients who do not present for routine screening. Factors such as age, medical history, and family history are used to determine when patients are due for health screening. Screening helps to identify if the patient is at risk of or has a disease or condition that was not previously known about. Health screening can pick up on diseases before a patient has any symptoms. Early detection of diseases may result in better treatment and management, which reduces the risk of complications while increasing the chances for better health outcomes. So this is a visual example of the guidelines for ASAP. This is recommended screening for the general population, but it's a good idea to consult with your family doctor for your individual needs. And the following slides will break down each of the recommended screening tests. So diabetes and cholesterol screening. ASAP guidelines recommend starting diabetes screening at age 40. However, depending on your health history, your doctor may recommend starting sooner. Diabetes screening consists of a blood test that's done every 3 to 5 years. There are often no symptoms with type 2 diabetes, and early screening may help people avoid the more serious complications of this disease, including chronic high blood sugar that's associated with long-term damage of the eyes, kidneys, nerves, heart, and blood vessels. Cholesterol screening is also a blood test and measures the cholesterol in your blood. ASAP recommends starting every 5 years for individuals between the ages of 40 and 74. However, your family physician may recommend different parameters based on your health history. Having high blood cholesterol can lead to plaque buildup in the arteries, increasing your risk for heart disease and stroke. High cholesterol doesn't have symptoms, which is why getting your levels checked is crucial for early detection and to prevent the associated risks. So lifestyle screening includes questions around tobacco, alcohol use, physical inactivity, and diet. These are all adjustable factors that are associated with increased risk of cancer and other medical conditions like dementia, heart disease, and stroke. Evidence supports the effectiveness of offering advice regarding lifestyle screening during interactions in primary care. Tobacco, alcohol, and exercise assessments on average begin at 18 years of age and are assessed yearly. Tobacco use includes smokeless tobacco such as chew and vaping.
When you visit your physician, you may have your height and weight checked periodically. Blood pressure should be checked yearly, but your physician may check it at most visits. If you have concerns about your blood pressure, a recent change in weight or height, and any other health concerns, it's important to let your physician know. So there are 3 types of cancer screening that are done with Alberta Screening and Prevention: cervical, breast, and colorectal. Cervical cancer screening applies to women and transgender people with a cervix who are or ever have been sexually active in any way. Screening can begin 3 years after the first sexual activity or at age 25, whichever is later. Screening can be optional for people in the age of 21 to 24 based on informed patient choice and or where the patient may benefit, for example, those at higher risk. It's recommended that you discuss having a PAP with your doctor if you've had a hysterectomy, as there's some cases where continuing screening is recommended. Ongoing communication with your healthcare provider can help you determine if cervical cancer screening is appropriate for you. Breast cancer is the most common form of cancer in women in Alberta other than non-melanoma skin cancer. Approximately 1 in 8 women is expected to develop breast cancer during her lifetime, and 1 in 31 women will die from the disease. So you can see why it's important for routine screening. Alberta Screening and Prevention Guidelines recommend starting screening at age 50 to 74 every 1 to 2 years. Red Deer has a facility called CAMUS that can do these tests. You should always discuss with your physician early or more intensive screening if there's a family history or determining factors. Colorectal cancer screening is testing that's done for males and females ages 50 to 74 to detect any abnormalities that could indicate a risk for colon cancer. A FIT, or fecal immunochemical test, is recommended every 2 years. This is a kit that you receive from the lab where you provide a small stool sample. This kit you this sample is tested for abnormalities such as hidden blood in the stool. This cues your doctor to send you for further testing. The colonoscopy is an exam that is typically performed every 10 years that allows a specialist to look into your entire rectum and colon to look for polyps or cancer. An individual should work with their physician when they are at an increased risk factors such as family history to determine how often screening should be done.
Okay, so I wanted to discuss prostate cancer screening because it's a common topic of interest in men. For some reason, the Alberta Screening and Prevention Program doesn't include prostate cancer. It might be because it is kind of a controversial area for screening. So we'll go over the recommendations from the Canadian Urological Association, the recommendations from 2017. So generally, prostate cancer screening is done through the PSA, which is called the prostate specific antigen. It's produced in the prostate and then it travels into the blood and we measure the levels in the blood. This test is usually offered as a screening test to men starting at 50 years old after discussing the risks and the benefits of the test itself, and we'll get to that soon. So individuals with a family history of prostate cancer and those who are Black may also want to be screened sooner, starting as early as 45 years old. Ideally, we want to screen individuals with a life expectancy of at least 10 years before we offer the test. So prostate cancer screening is usually stopped at about 70 years old. However, if let's say a 75-year-old who's relatively fit and healthy and have a much longer life expectancy, more than 10 years, it can still be offered in those individuals. So what are the benefits and the harms of PSA testing? One of the benefits is actually early detection and hence treatment of prostate cancer, especially those who are more aggressive in nature. So there are a few things to mention in terms of the harms category. Many times we're able to diagnose prostate cancer, but sometimes, actually I should say many times again, it's an overdiagnosis. And this results in overtreatment of prostate cancer that are low risk, that are slow growing, and that would actually have never caused any harm in the first place if we never discovered it. Eventually, if we want to prove that someone has prostate cancer because of an elevated PSA, we could move towards a prostate biopsy. But the biopsy in itself is potentially harmful as well. So a small gun is shot into the prostate, and it's done about 12 times, and they take small samples from the prostate. So as you can imagine, this can lead to complications like bleeding, infection, pain, and sometimes even bowel or bladder issues. There are times where the PSA test provides a false positive test, and this can also lead to biopsies that are unnecessary. It can also lead to a lot of anxiety and worry as well. So in the end, when we talk about prostate cancer screening, we want to approach it in a shared decision making model. That is, the physician and the patient should have a discussion again about the harms and the benefits of prostate cancer screening, and come up with a plan as to whether it should be done or not. And having said that, I will hand it over to Nadine for some success stories.
All right, so we have a few success stories we want to share. The first one's an early diagnosis of a stage 1 colon cancer. So with this one, a patient was notified they were due for colorectal cancer screening, and then they agreed to do a FIT test, which came back positive, meaning there were traces of blood in the stool. The physician sent them for a colonoscopy, which is standard protocol following a positive FIT test. The colonoscopy revealed a 5 by 5 centimeter polyp that was biopsied and came back positive for cancer. The patient was then scheduled for removal of the tumor, resulting in a short 2-day hospital stay. It's important to note this person did not report any symptoms leading up to their diagnosis. No further treatments were required because of an early diagnosis, and I am happy to report this patient remains cancer-free 2 years later.
So this next success story is from Alberta Screening and Prevention regarding an early diagnosis of invasive breast cancer. Life can get hectic. I didn't know I was due for my mammogram. I was seeing my doctor for another reason, and I was sent for a mammogram. The early diagnosis of invasive breast cancer that no one could see or feel saved my life. It's a relief to know my medical clinic has my back. So now we have time for some questions. And while we're answering these questions, there are some resources that we'll put up on the screen where you can find some more information. Doesn't look like we have any questions in the chat. So we do have some common questions that come about while we're discussing things with our patients.
Oh, Jenny, it looks like, oh, no, there are no questions.
No questions.
Okay.
So the first question is, should I still be doing my screening during the COVID-19 pandemic?
Yeah, so yes, you should be. You should be. When the pandemic had begun, our health resources actually were quite constrained because of all the COVID tests that we were trying to do. And the lab did ask us to forego stool testing and any other tests, blood tests, I should say, that was not very urgent. But now we are able to proceed with stool testing for colorectal cancer screening. We can also screen for diabetes and cholesterol and so forth. So as long as the facilities are open and able to do the screening, we should. Camus continues to screen for continues to allow us to screen for such things as breast cancer as well. And we've been still doing that during the pandemic. So in the office, we also still continue to screen for blood pressure, height, weight, and exercise, alcohol, and smoking as well. So yes, we should continue to screen during the pandemic.
Awesome. I have another question. I'm not comfortable with doing mammograms. Are there any other options for breast cancer detection?
Yeah, so that's a really good question. So for screening purposes, mammograms is actually the best option, as much as it's not the most comfortable option. It's the best studied tool for screening, and we know that it does reduce breast cancer deaths. Other forms of imaging includes ultrasounds and MRIs. However, we usually reserve those forms of imaging to follow up on abnormalities that we find on mammograms. So that's for average risk individuals. There are some individuals who do need breast MRIs, and those are individuals who are much higher risk. So I'm thinking about individuals who are known to have genes within the family that puts them at a much higher risk of breast cancer. But for average risk individuals, we would normally recommend mammograms.
And the next question is, I have had a hysterectomy. Do I still need to do pap smears?
Yeah, so that comes up actually quite a lot in the clinic. It really depends on why you had the hysterectomy in the first place. So if you had a hysterectomy, but the cervix is preserved, and I don't know if they even do that anymore. If you still have the cervix, despite having the uterus removed, then you would continue with Pap smears and cervical cancer screening as you would normally would. If the uterus and the cervix was removed for benign reasons, then there's no requirement for screening anymore. So when the uterus and the cervix is removed, all that remains is what we call the vaginal vault, which is just a lining of the vagina. If you did have a previous high-grade lesion on the cervix or even cervical cancer, when the hysterectomy was performed with the cervix removed, then we would still screen with a swab of the vaginal vault, and that's the same as the Pap smear.
Great. And another question, do I need to fast for my screening lab work?
So fasting is a bit of an inconvenience for patients. There used to be a time where we required patients to fast for cholesterol testing, but studies have shown that it doesn't really affect how we calculate a patient's risk of having a heart attack from the cholesterol value. So nowadays, for convenience, we ask patients not to fast anymore for cholesterol testing. There are times where you do need to fast depending on what blood test your family doctor has ordered, in particular with diabetes screening. So there's a fasting diabetes blood test where you obviously need to fast, and then there are other ones that you don't need to, like an A1C. So I would check with your family doctor when they provide you with the requisition, and you can ask them if there's fasting required.
Thanks. Now another question, where can I get a FIT test?
So I believe that is actually just provided by the lab. We used to do the fecal occult blood testing where you smear the stool on the specimen, or rather on the paper test, and you required 3 tests, I believe. And that was provided to patients from the clinic. But since the advent of the FIT testing, we don't carry those anymore in the clinic. And I've always just provided a requisition for patients to pick it up at the lab.
And our final question, do I need to have a colonoscopy?
Yeah, so a colonoscopy is one of the screening tools for colon cancer screening. It's really based on patient preference. So I usually order the stool testing for patients. We do that every year. It's much more convenient to do. The colonoscopy can be requested by a patient if they like. If the patient is quite adamant about doing the colonoscopy, then we can always do a referral to a specialist who's able to do that. Generally, we reserve the colonoscopy for higher risk individuals if they've had a family history of colon cancer, especially early colon cancer or polyps. We tend to choose colonoscopy over the stool test. So not everyone needs a colonoscopy for colon cancer screening. It's expensive, it's cumbersome, and there's lots of preparation that the patient needs to do before the test, and some patients just don't want to do all that. So a FIT test can be much easier and convenient.
Well, thanks so much for answering those questions, Dr. Nath.
Yeah.
So this concludes our health screening presentation. Thank you again to Tatiana and the Red Deer Public Library and Dr. Nath and my colleague Nadine. And thank you to everyone who joined us today for our Health Cafe.